All right, part one, we'll cover the powers and laws of public health in Montana. And so I wanted to bring this picture in here because some of the images that we're seeing here look a little too familiar in 100 years later. These images were taken from the 1918 influenza pandemic that we all have heard about. You can see scenarios here that we are unfortunately seeing again now. We're seeing folks mass producing masks. We're seeing signage on windows of how to stay healthy. We're seeing ill persons being transported with healthcare personnel wearing personal protective equipment. And unfortunately, we're seeing a lot of deaths as well. So fast forward 100 years, the images are very real and very similar to what we saw in 1918. Though of course there are differences we'll go into as well, but it just wanted to show these images as an example of the magnitude of this outbreak that we're currently experiencing in Montana, in the United States, and in the world. An outbreak of this size and magnitude is something that most of us will probably only experience in a lifetime and requires a special preparation and special response in a way that is not our day-to-day activity that we usually see in Montana. So just a couple of highlights between those two different pandemics. Again, there are some similarities and there are also differences, but there are some things that we are doing now that we did back then to help protect the health of the public. And it's really interesting to show how history sometimes does repeat itself. Back in 1918 and also with the 2019 COVID, there are new strains. And because these are new strains, we're dealing with a novel population, a population that has never been exposed to that particular virus. There's obviously no vaccine available at the time of this training. There's no vaccine available for COVID. At the time the influenza outbreak occurred, there was no vaccine available then either. Now, we do have, of course, made great advances in our healthcare environment, in our public health environment. We have now antibiotics that are available to combat further bacterial infections that may result from the initial infection. We have antiretroviral therapies that are being investigated. We have antiretrovirals in general that were not available 100 years ago. The 19 influenza outbreak seemed to have impacted the young, the very young, and the elderly the most, with a unique, what they call a W-shaped distribution, where folks who are between 20 and 40 years of age also seem to have been impacted quite a bit. With COVID-19, and this is, I will caution, is preliminary data because we are just in the beginning of this outbreak, and we know only so much, and a lot can change over time. But what we're seeing so far does seem that the elderly population is affected the most, and we are also seeing a larger impact on minorities and those who have underlying conditions. The 1918 influenza, it was anticipated or estimated that about a third of the world population was infected. That equates to about 500 million people, and about 3% of the population have died. They're estimating about 50 million deaths. That's a lot of people at that time. Our population now is much bigger. The world population is 4 or 5 times larger than it was 100 years ago. And right now we're looking at about 5% of the global population have been infected. And again, of course, that can change, and that is changing as we progress in this outbreak. Right now, the case fatality rate, it changes. Again, it could be in some areas it's higher than in other areas. It depends on the setting, but all in all, it's somewhere around the 1%. But again, that is preliminary data and will definitely change over time. The one thing that is kind of interesting that I wanted to draw attention to is the similar approach of non-pharmaceutical interventions. When we talk about some of the public health laws and rules as we go through this presentation, you will recognize where some of these authorities are coming from. But back then and now, we are employing isolation measures, quarantine measures. We encourage good personal hygiene like hand washing. We're using disinfectant. You're hearing things about limiting groups or keeping distant from other members in the community to avoid that spread in the population. So it's fascinating to see that these non-pharmaceutical interventions are now being employed again because they are effective and they're working. So just wanted to draw some comparison here to show an outbreak of this magnitude is not something that we see every day or every year. It certainly is something that we may see once in a lifetime. So how we are operating in public health and all of the work that we're doing is all scripted out in our laws and rules in Montana. And I want to just go one step back to kind of show where all this is coming from. If we go back to our Constitution, it talks about that it is our job to promote the general welfare. As written in the Constitution, and though there's no specific language for public health law in the Constitution, we're going back to our 10th Amendment that then reserves the right to spell these powers and authorities out by the state governments and the people. So that's kind of like big background here to just kind of put things in perspective of the work that we're doing is coming from someplace. So the public health law, like I said, every state then provides their own powers and authorities that need to describe how public health is being done, what the law looks like. And the main thing is these laws are instituted to protect the health of the public, like we saw in the Constitution, to protect the general welfare. And this is often, or sometimes can be a point of contention too, because when this course is going into public health law, and when we talk about public health and public welfare, we're concerned with the health of the population, the general population, whereas medical care is concerned or oriented towards the health of the individuals. And with that, individual rights. So sometimes there can be some differences when we're looking at what measures are we taking to protect the public versus what inconveniences that causes maybe for an individual and the individual rights. So that's certainly something that public health law is very much aware of, and that's why there are laws and statutes and rules put in place that allow us to operate with consistency. So what does that look like in Montana? In Montana, we have statutes and we have rules. And we want to just kind of highlight they're coming from different places, and how they're being changed or initiated is slightly different. Statutes, are Montana Code Annotated. We refer to that often as the MCA. So when you're hearing MCA, then that's referring to Montana Code Annotated. That is written law that is actually passed by the legislature. It's usually relatively broad and general, and it does require legislative approval for any changes or amendments. So this is not something that's easily changed, and it goes through an official legislative process. The way you recognize statutes is by numbers that are separated by dashes. For example, we have 50-2-116, the powers and duties of local boards of health. So that would be a statute. Again, so when we talk about statutes, think law. This is something that is decided by and only changed by legislature. And then we have the rules. And we refer to those are administrative rules of Montana. And of course, we don't want to say that all the time, so we just refer to it as ARM. So our ARM are the rules, and I will show you the language that shows that where we have the authority to create rules. So based on these laws, we're creating rules. The laws may say like what needs to be done, and then the rules go into more specifics how it needs to be done. So that becomes a little bit more specific through the different departments, and the language becomes a little bit more granular of how what the process should look like. So the agencies, the departments can make these rules, they can create these rules. There's also a formal process and a formal public review process that these rules go through to make sure that they're appropriate, they make sense, that there's not any big discrepancies or concerns from the public too, that these rules would affect individuals and the general population. The way that you recognize rules is by numbers separated by dots. So here you see, as an example, 37.114.203. Those are the reportable diseases and conditions. So that's how you recognize the rules. So that's just a little bit of background to kind of understand when we talk about Montana Code versus administrative rules. So let's go into a little bit of an overview of the public health authorities in Montana. So in Montana, all counties are required to have a health board. In larger jurisdictions, sometimes, especially in the more populous areas, depending on the size of the number of residents that are there, there's also a city board required. And what you sometimes see is a combination of a county city or your city county health department. For example, Missoula has like a Missoula city county health department to meet those requirements in the different class sizes because of the size of that county. So one thing, this becomes really important too. Everything that I'm teaching you here about with the Montana rules and authorities, of course, applies to the counties in Montana. Tribal nations are sovereign nations, and they may adopt the local code, the code that I will be talking about here, or they may have a different set of code or no code at all. So it's really important, depending on where you do your work, that you understand what the local requirements there are, especially if you're in a tribal nation. Again, the local county health departments, of course, follow under the same laws and rules I'm presenting here today, but tribal nations do have their own rules and restrictions that they may apply or employ. The local boards of health, now this is under Montana Code 50-2-116. So just a quick summary, and there's so much more here, but I'm really just drilling it down to kind of the essentials that we are seeing here that are applying right now to the COVID-19, to communicable disease investigations in Montana. These are the highlights. I am making some reference to additional rules and Montana Code. If you're interested, I'll encourage you to research those further and read through the entire language in the authorities. So the local boards of health, they have to meet on a regular basis, and they are instructed to appoint a health officer and then also hire the qualified staff, and then highlighted here, to protect the public from the introduction and spread of communicable diseases. That's our primary role. This is what a responsibility of the local board, one of the responsibilities of the local board of health. One key component that is very important to understand in Montana is that we have a decentralized system. The authority lies with the local health department. The state health department may adopt and create these administrative rules, but this work is carried out with the authority at the local level, and I'll go into that in the next slide. The county attorneys are usually serve as a counsel to that board. So that becomes very important when we're looking at communicable disease investigations and control in Montana. So the health officer comes with a lot of authority to do this important work, and that's all laid out in the Montana Code annotated, 50-2-118. And this is just a couple of the items here. Again, I'm highlighting just the relevant sections here. There's, of course, more in these codes if you would like to read further. But a local health officer, for example, can make inspections of restaurants or other places, places that we as a public visit. We want to make sure that when we go to a restaurant that the operations are safe and sanitary, and if they're not, that then the local health officer can issue corrections or things that need to be done to correct, to make sure that it's safe for the public. A local health officer can also take steps to limit contact between people. If there's a threat in terms of disease transmission. This is why you're seeing building closures or that group events are canceled. This is where that authority comes from. They're also required to report communicable diseases, and we'll cover that here in a little bit. And create quarantine and isolation measures and so forth. And like I mentioned earlier, the authority lies with the local health department, the local health officer. So some of these very specific instructions or how quarantine or isolation measures are prescribed could vary from county to county somewhat, depending on, again, what the local health officer decides. One important piece that I need to highlight here as well, when we refer to a local public health officer, we refer to an entity, but because one person can't do all of this work themselves, of course, they often delegate this work. And for example, when it comes to reporting a communicable disease, let's say you were diagnosed with salmonella, which is a reportable condition. Most likely you will receive a phone call from a public health nurse who is doing this work, this kind of follow-up, under the authority that it was delegated to that person from the health officer. All right. Then the health department also has certain authorities. This is still coming from the Montana Code Annotated. And again, this is a very long list, and I'm just picking out a couple of the items here that are very relevant to what we're talking about, that the health department can do: epidemiological tracking and investigations. They can do the isolation and quarantine measures. And the next piece, this is what I alluded to earlier, it allows the department to adopt and enforce rules that pertain to the reporting and the control of communicable diseases. And that's what we're going to cover next in our administrative rules. All right, so now, as you notice, the numbers are now separated by dots. Now we are looking, what we're talking about are the administrative rules of Montana. These were then written and adopted, by the department. And this is sort of the starting point. Before we can respond to any disease outbreak or even one case of a reportable condition, we need to hear about it, right? So in this section, it talks about who needs to report a communicable disease. And 37.114.201 addresses who can report, and it's really any person. Most likely it's probably, a physician that, may diagnose a person with measles, or for example, in the office, they report that to the health department. Or a laboratory test is run to diagnose somebody with salmonella, then the laboratory reports this to the local health officer. Again, we're talking also delegates. But it could also be any person. It could be a school nurse, for example, who's noticing a lot of children with a diarrheal illness, and they need to report that to the local health officer. So it's not limited to certain people who can report, but of course the majority of disease reports are coming through the healthcare kind of channels. So that's what it's spelled out here, and there's also additional language in the Montana Code that I referenced in the slide at the bottom of the slide if you want to read more. So there is that requirement to report communicable diseases. I don't have enough time to go into all of these different components of what that disease report looks like, but basically, if you're interested going into and learning more about what are the conditions that are reportable, there's quite a lot of them. There are also reporting timeframes. Some conditions need to be reported immediately. Something like a novel influenza, for example, or novel coronavirus is something that's reported immediately. Others, there may be a few days of time before it needs to be reported. It also goes into report content. What kind of information does the health department need to actually begin reaching out to a person and start an investigation? And when we refer to an investigation in public health, it is not a criminal investigation. Nobody's in trouble when they're diagnosed with a reportable condition. What we're talking about is an epidemiologic investigation. And we'll go into that here, right, in that next slide. So when we're investigating a case, what we're trying to do is we're trying to figure out, where did it come from? How do we stop it in the community? How do we make sure it doesn't spread any further? There's also requirement in the 314 rule that talks about then that is our responsibility as the health department, the local health department, to reach out to contacts and notify them that they were potentially exposed to a communicable disease. Because if you don't know that you were exposed to it, and we don't take appropriate measures like quarantining contacts, isolating cases, then then we can't stop the transmission. So that's telling us how we need to respond, with what kind of control measures we need to respond to what condition. So in 314 goes into that the health officer then must do the investigation, make sure we control any further spread, and notify the contacts. So then in our administrative rules, we are addressing how the conditions are to be, what we need to do to control the spread of disease. Some conditions require different responses. Somebody who may be diagnosed with sexually transmitted disease would require treatment to effectively stop further transmission, and other, behavioral maybe changes to stop spread. In other situations, for example, if you're diagnosed with COVID, these control measures may be that the person is then isolated, so cannot mingle with other people, because the way that disease is transmitted is different than other conditions. So each condition has its own set of requirements of what's effective at stopping it. And we have adopted the Control of Communicable Disease Manual as our guide, as a scientific evidence of how disease is best stopped. And that's the manual that we refer to. We have adopted this in our administrative rules to say, this is our response to a disease based on this document. So all of these items in terms of how a disease is reported, what the health officer needs to do in terms of the follow-up, contacting individuals, and then what measures need to be taken to control the spread is all outlined in the administrative rules of Montana. And those are the important pieces to know when you're doing case investigation and contact tracing for COVID. So that then brings me to a lot of that information sharing and confidentiality, right? So when somebody goes to a provider, gets diagnosed, there's a condition that is now associated with that name. That name is then, as we saw in the rules, being shared with the health department. The health department will do what they need to do that's their job. That is written into those rules, that they need to do the follow-up and make sure that there's no further spread, that the person is either treated or that the transmission is controlled in some capacity as outlined in the rules. And there may be concerns of, well, that's a lot of information that's going out, and who all will know about this. Well, rest assured, there are also, there's language in our Montana Code annotated, of course, that spells out who can receive certain information. And this is very, very strict. The health department, when we do follow-up for disease investigations and control, the information that is being shared with us is very specific, and it is kept confidential and can only be shared in certain circumstances, and it's only really for the purpose of stopping the disease transmission. So a lot of this information cannot be shared with relatives or other people or the media or things like that. That information is protected with the health department and cannot be shared. This is a really important Montana code. It's under the Government Healthcare Information Act 50-16-603, goes into the confidentiality of healthcare information. Now this is pertaining to the health departments, the local health departments, state health departments. The only way that this kind of disease information that we are collecting can be shared is laid out in this chapter. We can share it for statistical purposes if no identifying information is released. That's why you're seeing, aggregate disease reports, the maps, the epidemiological curves on the website. And it helps raise awareness because it creates that transparency to say, this is happening in our community, and we want to make sure our community is aware of it so they can take steps to protect themselves, like wearing masks or not going to group events or washing hands more frequently during that time, those kinds of things. But no identifying information is shared at this time. It cannot be, will never be. The only other time information could be shared is if that person with that infection has given written consent. Sometimes that may happen in a case of, let's say, a foodborne outbreak. Somebody was part of a large foodborne outbreak and the food item was implicated, there was a recall, and maybe that person had to be hospitalized and had medical bills, and they're using a lawyer to basically get some of the funds back from the hospital bill that they had. So in that situation, that person would then be very specific and have written consent to say, I'm allowing the health department to release my information about this to that person who's representing me. So again, this is a very limited and restricted time where that may happen. Of course, that information can be shared to medical personnel in an emergency, you know, if the health or the well-being of that named person is in jeopardy. So there's certainly that component. But again, that's not relatives or the media or other situations. This is very restrictive. Now, where we can share information, of course, is, you see that under the 5, is with other state and local health departments, and that is for the purposes of preventing and interrupting disease transmission. So that's where that information can be shared, and again, it will be kept confidential at all times. So this is a question that we get a lot, you know, in terms of what information can be shared. Will become relevant when you were talking about case investigations and contact tracing. When if you are a contact tracer, you're attending this course to become a contact tracer, and you've been given a name to reach out to somebody who is a potential contact, you cannot share any information if you even have it. Even if you had it, you cannot share any information about that index case to the contact. That's how it works. That information is extremely protected. There are some additional items in terms of confidentiality that are not necessarily applying here. You know, Section 6 goes into if there was abuse, there's some allowance for sharing information, and if there's any other code or law that needs to be enforced, again, regarding the prevention and control of diseases, it can be shared. So this is very restricted. The information that you have in terms of cases who have been diagnosed with a communicable disease must stay with the health department and can only be shared for the purposes of the disease control. So healthcare providers, it's a little bit different situation. This course is not designed to go into the confidentiality laws and rules for healthcare providers. Of course, they are under HIPAA, the Health Insurance Portability and Accountability Act. They have their own restrictions and requirements. What I will highlight is just a slight piece out of the Montana Code regarding minors, because that is something that we may run into. And here's some additional language where a healthcare professional can release some information about that minor. And again, it's very scripted of what that might look like. They may be able to inform a parent, for example, if there is serious jeopardy to the health of that minor or siblings or the public. Again, very, very prescripted. All right, then one other piece that is something that when the public health folks who are working in public health, and when we're doing the communicable disease reporting, investigation, control, we usually don't deal with this portion of the Montana Code annotated. Most of the communicable diseases and outbreaks that are being investigated happen on a much smaller scale and on a daily basis. But like I alluded to earlier, this outbreak is of great magnitude, and it has affected already every single Montanan, every person in the United States and in the world. It's a huge pandemic and requires much more dramatic measures, so to speak. So that authority comes then from the governor's authority. I'm just going to reference some of the Montana Code annotated, and you will find those also in the directives. When you're looking at the directives the governor puts out, you will see references made to, for example, 10-3-104. It talks about what the general authority of the governor is, that they can, you know, make changes or to the rules, to the laws. There's additional language about emergency situations under the 500 code that talks about in an emergency what can be done to change. You know, these are special circumstances. This is a special emergency situation, and with that also has an end point, right? So when we're looking at the directives and the emergency declarations, there's usually an end point to this. So this is a temporary additional authority where everything that I just described in terms of how this work is being done could potentially be modified as needed by the governor if that seems to be something that needs to be addressed. In a pandemic of this proportion, there may be things that will have to be addressed. So that's where that authority is coming from. That's why we are seeing governor directives that put the state on a lockdown or a stay-at-home order and things like that. And if you look in the directives, you can also see that the governor also is citing some of those Montana codes in the 50s, where we're talking about the authorities of public health and the quarantine, the isolation measures, the staying away from other people, the social distancing and so forth. So that's where all that authority is coming from. And then one more highlight in regards to additional authority. Again, this is more of a reference for those of you who would like to read up a little bit more on it. Under special circumstances, rarely ever used, but if needed, the authority is there. Public health can ask for assistance from law enforcement officials. Sometimes if you have a situation where somebody is absolutely not cooperative, maybe somebody needs to come in for direct observation for treatment and they're just not complying and they're posing a serious threat to the public, to the general public, based on their behaviors, they may be needing help from law enforcement to make sure that this person can get the treatment or whatever the measure is that needs to be implemented to make sure that the general public is protected. And there's also some additional language in there that talks about obstructing a health officer is unlawful, that a public health officer should not be hindered in performing their work, and talks also a little bit about the fines and the misdemeanor charges that could accompany when somebody is not cooperating with written public health orders. So just know there is some additional language there. We hardly need to go there, but it is written into the law and approved by legislature that there are these measures in place and the authorities in place with some teeth behind it to say this is important because we're doing this to protect the public.
From the most recent legislation, House Bill 702 was enacted. This bill prohibits anyone to be discriminated based off of their vaccination status, such as a vaccination passport. This impacts how we conduct contact tracing and case investigation in the state of Montana. It is important to rely on your county attorney to get feedback on what guidance you can and cannot be giving people based off of their vaccination status, as the CDC does have different recommendations based off of whether someone is vaccinated or not. Two additional areas of note for House Bill 702 is that this section does not apply to the vaccination requirements set forth by schools and daycare facilities. The second is that a licensed nursing home, a long-term care facility, and assisted living facilities are exempt from this due to them being in violation of the guidance and regulations set forth by Medicare and Medicaid services. Again, it is important to check with your county attorney to make sure you're not in any violation of House Bill 702.
I wanted to just end with a few examples of, why do we have all these rules, right? I mean, if one, we want to make sure we operate consistently, across the different counties in this state to follow up and make sure that we can respond to communicable disease threats and outbreaks. But these are just some examples that allow public health to do the work that they need to do. For example, unsanitary operations can be closed. If a restaurant is operating in such a manner that it puts the health of the patrons at risk, the health officer can step in and say that's not happening. We need to fix this. We need to correct this to make it safe for folks to eat here. Some vaccine requirements that you see in school settings, for example, create that herd immunity to make sure that we are not seeing outbreaks of certain vaccine preventable diseases in school settings. For tuberculosis, for example, in Montana, direct treatment would be directly observed. We have very, very few cases of tuberculosis in Montana. And to keep it that way, every individual who's been diagnosed with tuberculosis would then make sure that they get the treatment they need so that way they don't transmit it to others, because it is airborne and it's very easily spread from one person to another if that person is allowed to spread the virus. Another thing you've probably seen in the news too is a recall of contaminated food items. When somebody is diagnosed with a diarrheal illness, for example, and this investigation, this epidemiologic investigation occurs, they find out, you know, what people have been eating, and there may be other people who then have similar exposures, what we call them, and they identify a certain food item. Well, then that food item can be recalled, can be pulled off the shelves. That's the authority that we have to do that. The local health officer has that authority. And then that contaminated food item is removed, public has no longer access, and therefore we can prevent further illnesses. And of course, you know, that's why we're all here in terms of COVID-19. I already alluded to some of these, right? Social distancing are measures that can be recommended. They can be, you know, mandated. I mean, it depends on the local health officer and their discretion at times to how exactly these isolation and quarantine measures, what they look like in that county is then determined by them. Or, you know, the governor having directives that override some of those things. So that's why we can do those things, and they are, again, done to protect the health of the public. And that concludes part one. Thank you for tuning in. And in the next part, we will talk about how to conduct the case investigations and contact tracing for COVID-19 in Montana.